Assalamualaikum and hello guys, welcome to Carnation Space. So last time we are covering the breast cancer CPG 2010, and here we are going to continue with the treatment. Okay, so treatment, as I said, there are surgical treatment, chemotherapy, and a lot lah, endocrine some more. So let's start with the surgical management. Okay, surgical management in early breast cancer. Last time we have radical mastectomy. Now we have breast conservative surgery. Okay, and also assessment of the axillary lymph node. If we look at here, breast conserving surgery and radiotherapy offer the survival benefit as modified radical mastectomy. So why go through the hassle to do the radical mastectomy when you can actually do breast conserving surgery for the same result? But of course, this one must accompany with radiotherapy. Okay, so early breast cancer, we can do this breast conserving surgery and mastectomy. However, there are a few contraindications for the breast conserving surgery. It depends on the size and the ratio of the tumor to the size of the breast. Okay, and also based on the location. If it affects the cosmesis, then it is contraindicated. And if it multicentric, multilocal, too many at the quadrant, so it's contraindicated. And then if the radiotherapy is contraindicated, because BCS must accompany with radiotherapy. And then some other lah, like connective tissue disease and pregnancy. You cannot do radiotherapy to a pregnancy because of the risk of fatal deformity. Okay, so basically breast conserving is one of the option in centrally located tumor, but we may require excision of nipple and areola, so cosmesis compromised. This one we need to discuss with the patient. And then regarding the tumor-free margin, how far do we do the surgery again? If the surgical margin is less than 2 mm, we must consider several factors if whether we need to do re-excision or not can. So what are those factors? Age, histology, with the presence of lymphovascular invasion, grade, extensive in situ, and it is lobular carcinoma, then we need to do the re-excision. And then if the margin is approximated by the tumor, no, this one smaller margin is acceptable. And then the extent of the cancer. Okay, for the complete excision, therefore what I'm trying to say is that we need to do the complete excision with clear margin. That means either equal or greater than 2 mm. Okay, axillary surgery again. Axillary surgery, we must do axillary lymph node dissection. Either we remove 1, 2, or 3 level of the nodes to the pectoralis minor. And how much of the lymph node? Basically, typically 10 to 15 lymph nodes. Okay, and then we must check it under hematoxylin and eosin. And then if we look at here, axillary node dissection is more effective at lowering the risk of recurrence. Okay, when we do the BCS, the rate of recurrence is quite high. I think about 20%. So if we do the axillary lymph node dissection, the local recurrence rate will reduce dramatically. And then you've heard about sentinel lymph node biopsy, kan? So who are indicated for the sentinel lymph node biopsy? Okay, there are no data on whether you want to do sentinel lymph node biopsy ke you want to do dissection of the lymph node, kan? So no data for this patient lah. Tumor 3 cm multicentric, positive node, pregnant, allergies previously treated. So what? What are the conclusion? Either you want to use sentinel lymph node ke you want to do the dissection. Lastly, what I'm trying to say is sentinel not carried out if there is clinically involved nodes. Why? Because as I said just now, because there are no data regarding that. Okay, we don't know whether it's going to improve the mortality or not in this patient lah. If the breast cancer is more 3 centimeter, so we do not recommend in this patient. And then sentinel lymph node. So who do we do? Sentinel lymph node is quite famous kan when we were studying in med school. So we do it only if the breast cancer is less than 3 centimeter and there is no clinically non-palpable node. Okay. Because if we palpable, then we better do dissection lah. Why do lymph node sentinel biopsy kan? And then this one must be done by surgeons who are trained, and then by doing the dual technique aceto-M blue dye. Okay, a question: whether you want to do breast reconstruction immediately or delayed kan? So the answer is there's no difference. It says here one of the studies said there's no difference in recurrence rate whether you do immediate reconstruction or no construction. But another study differ pula. So before that, do we use the reconstruction and we use the TRAM. What is TRAM? It is transverse rectus abdominis myocotinus, and this one, if we use this, it shows that we have 87.5% late complication. Okay, so there are possibility that radiation will pose a distorted contour due to flap contraction in radiation therapy. So the answer is this one. Reconstruction is delayed until radiation is completed. Okay, because there's no use if we do the reconstruction but it's going to be compromised also, the cosmesis. So caution before offering the immediate breast reconstruction in patients who are active smoker and obese, and immediate breast reconstruction only offered after the adjuvant kan, and then the free this one the same after the radiation. Okay, neoadjuvant chemotherapy. Neoadjuvant, because mostly breast cancer is micro metastasized kan, it's basically a systemic disease. So neoadjuvant locally advanced breast cancer is invasive, and then it has the following features: bigger than 5, several lymph node in axilla, lymph node in skin, muscle, ribs, but there is no beyond breast region. This one is advanced but only locally. Okay, it differ from the early breast cancer. And then it says here radiotherapy. It reduces the local regional recurrence and improves survival following the neoadjuvant chemo and mastectomy. So we do this neoadjuvant chemotherapy to downsize the tumor. This one I got in my examination. The indication why do we do the neoadjuvant is we want to downsize the tumor. Okay, the factor affecting response to neoadjuvant kan. So there are following factors. Neoadjuvant chemotherapy is better response in ER negative tumor. Okay, ER negative tumor, and if the combination of taxane and anthracycline it pose with the biological Herceptin, it pose a response to HER2 positive. So remember, ER negative neoadjuvant chemo, HER2 positive we use taxane, anthracycline, Herceptin. And then for non-lobular, high-grade histo, high Ki67, luminal B, this one it has higher chance of response for neoadjuvant chemotherapy. And this one is ironically for lobular type and low Ki67. One is considered for neoadjuvant endocrine therapy or mastectomy for lobular type and Ki67. Okay, neoadjuvant chemo is a systemic therapy, and then it leads to downsize the tumor. Okay, for surgery in metastatic, like we know metastatic breast cancer, most of it we relate with palliative. But before that, do we need to do surgery or not? This one. It says here the 5-year survival rate is actually higher with mastectomy compared to without mastectomy. So we do lah. Even though patient already in stage 4 breast cancer, surgery of the primary tumor may be done, may be considered. Okay. How about resection of metastasis? Let's say the cancer already metastasized to the brain, kan? And then resectable, yes, we do also. And if the tumor metastasizes to the lung and liver, yes, we do, because it may pose benefit. If the cancer is less than 2 cm. Okay, so regarding the systemic therapy pula, there are a few indications. Okay, this one I say breast cancer is systemic condition, and there are very high risk of distant micrometastasis. So we must do adjuvant chemotherapy. Okay, so death rate and stratification are immediate and high risk. So this is a stratification. Now for the high risk patient, nodal, node 1 to HER2 overexpression, or node 4. Okay, and then for the recommendation, adjuvant chemotherapy must be considered in all patients with early breast cancer because of the what? Because of the micrometastasis. And then the adjuvant chemo also offered for patients of the following risk. Patient already have positive axillary lymph node, ER negative, HER2 3 plus disease, tumor size 2 cm, and grade 3 disease. Okay. For the neoadjuvant chemotherapy, what are the indication and what are the benefit? Indication because we want to eradicate the micrometastasis, kan? And then we do it for patients who are advanced, but neoadjuvant not routinely done for patients with early breast cancer. Okay, what are the neoadjuvant chemo drug? These are the example: paclitaxel, doxorubicin, cyclophosphamide, methotrexate, and okay. For taxane-based regime, what are the indication and what are the benefit? So it says here taxane is a benefit, and for the NICE guideline recommended we use docetaxel if patient who have lymph node positive breast cancer. Okay, so you've heard about FEC and CMF, kan? FEC 5-fluorouracil, epirubicin, and cyclophosphamide. CMS is cyclophosphamide, methotrexate, and 5-fluorouracil. So with the FEC or CMF, which one do we want to use, kan? Some book says FEC, some book says CMF. So the Malaysian guideline says there's no difference in disease-free survival. The only difference, the only question that we need is whether we want to use epirubicin 100 mg or 60 mg. So the answer is we use 100 mg because it improves the survival about 4%. Which is quite high. Okay, and then if we use the docetaxel, it also improves 87. You can read on your own that one. Okay, the recommendation for the lymph node positive breast cancer, we use taxane as the docetaxel as the adjuvant chemotherapy. Alright, and this one is HER2. Let's continue HER2 in later video. That's all for today. Thank you for listening. Bye bye. Oh, I also want to say, you guys, don't forget to do whatever the things that your future self will thank you for. Okay, bye.